Hello, class, and welcome to today's lecture on schizophrenia and psychotic disorders. And in our exploration of the developmental psychopathology, we're going to look at some of the more misunderstood realms of mental health. With our focus on schizophrenia, which is a complex and multifaceted disorder, will hopefully provide some good context and understanding of this disorder and some of the historical context that goes along with it. Now, hopefully we'll also understand and begin to appreciate the experiences of individuals affected by schizophrenia. Now, this diagnosis has challenged researchers and clinicians and society at large because it is such a complex disorder. There are many different aspects to it. In fact, in some ways you could say there are schizophrenias rather than just that one term. But in this lecture, we're going to cover some historical perspectives, some key contributors. We'll look at the symptomatology, the prevalence, and the crucial need really for destigmatizing this disorder. So, as we dive into this disorder, as always, I'd like to give you a little bit of a story about some key researchers in the field. We'll then take a little bit of time and look through the historical perspective for understanding schizophrenia, because the approach to schizophrenia has changed significantly, particularly across the 20th century. And there's been some significant changes as far as societal perception, medical advancements, and shifts in terminology related to schizophrenia. We'll also shine some spotlight on some key definitions. What do we mean by the term schizophrenia and the broader category of psychotic disorders, as well as how has treatment and our understanding of the neurobiology changed over time. And all of this, I think, will give you a very healthy appreciation for the experiences that people have and the wonderful ways that we can now treat this once mysterious disorder. So I'd like to start off by introducing you to a very prominent researcher from Nebraska through to Iowa, Dr. Nancy Andreasen. She's a distinguished psychiatrist and neuroscientist. She's born in 1938 in Lincoln, Nebraska, and has spent a great deal of time during her academic career in Iowa, at the University of Iowa. And she's really well recognized for her work in understanding the neurobiology of schizophrenia, as well as identifying some abnormalities in the brain structures of schizophrenics. Andreasen has also contributed significantly to the understanding of various types of symptoms of schizophrenia. For example, there are what we call positive symptoms as well as negative symptoms of schizophrenia, and she's given us some great insight into that. She's also conducted some longitudinal studies tracking individuals with schizophrenia over extended periods of time in order to get a better understanding of the deep appreciation of the progression of the disorder. And also, her understanding and contributions extend to the realm of genetics and the environmental factors that play into it. We've always known that there's been genetic and environmental factors, but she and her team have done a lot to unravel the complexities of schizophrenia. And so she has been one of those people that you will always see in the literature as somebody that is a leader in this field. So it's important to be mindful of such leaders. Now, let's take a look at our understanding of schizophrenia and journey back all the way to ancient times. Now, in ancient times, symptoms that might align with what we call schizophrenia today were often attributed to supernatural forces or sometimes to divine punishment. In individuals that would display these unusual behaviors or exhibiting disorganized thought were frequently seen through a spiritual or religious lens. And then during the Middle Ages, mental illness, including what we now recognize as schizophrenia, were often linked with a specific type of spiritual lens. Were often linked actually with what was called demon possession. And the treatment approaches were steeped in a great deal of superstition, and that's where you get the whole idea of exorcisms and other ritualistic practices. Now, in the late 17th and 18th century, the establishment of asylums marked a significant shift towards a more structured care for the mentally ill. However, these institutions often provided little understanding or effective treatment to those with schizophrenia because of the limit of the scientific technology and understanding of the time. And toward the end of the 18th century, there became a trend to be more humane in the treatment of individuals with mental disorders. It began to be seen as an ethical and moral imperative to provide compassionate care for individuals with mental disorders. And while this represented some progress, the understanding of schizophrenia remained limited, and treatments varied widely in their efficacy. So, in essence, the pre-1900 period really witnessed a historical landscape where explanations for what we now recognize as schizophrenia was deeply intertwined with cultural and religious and supernatural beliefs. Now, having said that, there are still many people today that still view schizophrenia through these lenses, and it's something you can't really get away from. Just recognize that from the medical and scientific view, at least, we've moved on to a better understanding. Now, I want to also talk just a little bit about our understanding of schizophrenia and how it has kind of changed over time. So the early 20th century, and we had a bit of a eugenics influence where the impact of genes gained some prominence. And so there was a focus on hereditary factors in mental illness, including things like schizophrenia. And so in the early 1900s, this period saw the rise of sterilization laws. And the goal here, an unfortunate goal to be sure, aimed at preventing individuals with mental disorders from having children. And the societal goal was to use whatever method was available to get rid of mental disorders within society. Now, obviously, that did not work, and but that is one of those kind of unfortunate practices that did take place. And then there was the Swiss psychiatrist Eugene Bleuler, who in 1911 introduced the term schizophrenia to replace, which literally you can think of it as two minds, where there's a breaking of the mind. And he used this term to replace the earlier term, which was dementia praecox. And dementia praecox was a term that was basically used to describe someone who is having a mental deterioration into disorganized thought. That's kind of literally what dementia praecox means. So the earlier term, if you look in the late 1800s, you will often see the term hypophrenia or dementia praecox. But after that, the terms hebephrenia and then schizophrenia come to the fore. So within the broader category of schizophrenia, Bleuler identified some different subtypes, and these subtypes that he identified were things like hebephrenic schizophrenia, which were characterized by disorganized thinking and behavior. And then in the early to mid 20th century, this really kind of witnessed the growing influence of psychoanalysis. So we have Sigmund Freud's theories. Now, while they don't directly explain schizophrenia, they did have an impact on the conceptualization of mental disorders in general. However, the psychoanalytic approach really struggled to provide a comprehensive understanding of schizophrenia. And to be fair, that wasn't Freud's specialty. Freud's specialty was more in the area of anxiety disorders, that type of thing. And so this isn't something that really fits into that. Now, in the 1930s and the 1940s, there were some somatic treatments that began to gain popularity. One of those was what is called insulin shock therapy, which basically induced a controlled coma through insulin, and also electroconvulsive therapy. These were introduced in attempts to alleviate some of the symptoms of schizophrenia. Now, while these were sometimes effective in managing some of the acute symptoms, these methods also had some significant drawbacks and some very serious ethical concerns. In the time of World War II, we see that there was some increased attention that was finally given to schizophrenic and psychiatric disorders, including schizophrenia, particularly for soldiers returning with mental health challenges. And so the advances in the United States in psychiatric research during this period is really what laid the groundwork for the development of what we now call antipsychotic medications that followed in the decades afterwards. So in essence, the first half of the 20th century witnessed some significant changes in the understanding and treatment of schizophrenia, and the term really started to come about. The term schizophrenia itself helped to identify that there were some subtypes to this and led to some more nuanced diagnostic categories within this broad field of schizophrenias. Then, as we mentioned, the 1950s came along. So the research from after World War II now is finally starting to take hold. And in the 1950s, we have a groundbreaking development with the introduction of chlorpromazine, which was the first antipsychotic medication. And this really kind of marks a significant shift in the treatment of schizophrenia, as these medications start to help to alleviate the symptoms and facilitate the deinstitutionalization of patients. See, up until this point, and you need to kind of remember, all through history, there have been people that have lost touch with reality, and now we have a medication that helps them to get back in touch with reality so they can start to take care of themselves again and start to function within society again. And we just can't overemphasize the power that has. And then when we have the latter half of that 20th century, we start to see a move away from the long-term institutional care for individuals with schizophrenia. So this deinstitutionalization really aimed to integrate individuals back into the community, with community mental health services taking on a more prominent role. And then we have in the DSM, particularly the DSM-3 in 1980, really brought about a shift towards a more categorical and standardized approach to diagnosing mental disorders, including schizophrenia. And so this began to facilitate some clear communication among clinicians and researchers, and that too helps, because when you have a clear phenomenon to study across the world, then researchers all around the world can share their information so that you can move the understanding forward much quicker. And this is when we see in the 1990s a new generation, a second generation of antipsychotic medications. And we sometimes call these atypical antipsychotics. And these medications were aimed to address some of the side effects associated with earlier drugs while maintaining some effectiveness in symptom management. And also, we have at this time the advances in neuroimaging and molecular genetics. And this extends into this century, where we get a better understanding of the neurobiological underpinnings of schizophrenia, and we get insights into how neurotransmitter imbalances, particularly involving dopamine and structural brain abnormalities, can play a significant role in the development of schizophrenia. So now what we have is this wonderful move to a more integrative approach, where alongside the incredible advances in psychopharmacological interventions, we have psychosocial approaches that have gained recognition as crucial components in schizophrenia treatment. And this helps to support employment, help support development of social skills, and the full integration of individuals back into society that otherwise would have been in institutions for their entire life. Now, let's go back and just kind of dive into what do we mean by schizophrenia? What does the term mean? What's the broader category of psychotic disorders? Well, schizophrenia is essentially a very severe mental disorder, and it's characterized by some disruptions in thought process. That is, in thought, that when we would normally see normal logical progression of thoughts, in schizophrenia, the thought process is not smooth. It tends to go all over the place and be disjointed. There's also disruptions in emotions, as well as disruptions in perception. That is, seeing or hearing things that no one else can see or hear. And so individuals with schizophrenia often experience a range of symptoms that can be categorized into both positive and negative and cognitive domains. Now, the term itself, schizophrenia, originates from the Greek word schizo, which means split, and phren, which means mind. But it's important to note that schizophrenia does not imply, it doesn't suggest that you have a split personality. That's dissociative disorder. That's a completely different disorder. And so it's often mistakenly believed to be that. Really, it kind of reflects a fragmented mind, a mind where thought processes and emotional regulations are fragmented. So, what do we mean by psychotic disorders? Well, we can kind of think in terms of, neurotic symptoms would be where there's trouble in mental processing, but a person is in touch with reality. Psychotic disorders, though, are where the person has lost touch with reality. So psychotic disorders involve disturbances in thinking and perception and emotional regulation to varying degrees, but individuals with these disorders may also experience hallucinations, delusions, disorganized thinking, and impaired insight. And so as far as the hallucinations go, that is that there's perceptions without any external stimuli. So this might be hearing voices or seeing things that others do not see or hear. Then there's delusions, and those are strongly held false beliefs that are resistant to reason or to contradictory evidence. Then there's disorganized thinking, which really is impaired thought processes, and this leads to difficulties in organizing ideas and expressing them coherently. There are also, if you recall, negative and positive symptoms. What do we mean by a negative symptom? Well, a negative symptom is the reduction or absence of certain capacities, such as emotional expression. So oftentimes we'll talk about schizophrenic having a flatness of affect. There's very little emotional expression that goes on, or very little motivation. And the ability to experience pleasure is diminished, that type of thing. Now, as far as the history of the treatment of schizophrenia and the profound impact of psychopharmacology, I want to kind of really circle back to that, because I don't think people really appreciate just how important psychopharmacology is for mental health and for the treatment of mental disorders. So again, I want to kind of reiterate what we've seen over the last 120, 130 years. In the early 1900s, treatment options were really limited with schizophrenia. There were asylums and institutions that provided custodial care, so they would be fed and watered and roof over their head, but that's about it. There was very little understanding of what causes schizophrenia. And if you recall, there was those somatogenic treatments like insulin shock and electroconvulsive therapy that had very limited benefit with a lot of side effects that could have potential real harm for an individual. And so it wasn't until the 1950s with chlorpromazine, I always get that one mixed up, chlorpromazine, that being that first antipsychotic agent. And some other first generation antipsychotics were things like haloperidol. And then that gets people out of these institutions, gets them back living in their homes and being part of the community, which is huge in the 1960s and 70s. And then we have better research in the 1980s. And then in the 1990s, we have a second generation of atypical antipsychotics, clozapine and risperidol and olanzapine come out, and they have much less side effects than the other disorders. The other pharmacological treatments. And so we make some huge advances there. And in the midst of all of this, though, we're still working on things. There are some side effects that do seem to come out, and they were very pronounced in the first generation of disorders, where if you were taking these medications over a period of years and decades, while it keeps you in touch with reality, it can cause very grotesque facial tics. And that can be very upsetting for the patients as well, because now they're being ostracized because they have these uncontrollable facial tics. But we are continuing to work on the medications in order to be able to get to a point, ideally, where there is a good balance of keeping the neurochemistry of the brain even, while not causing any structural damage to the brain that would cause any of these tics. Now, let's just explore a few of the negative symptoms. When we talk about the range of symptoms within this broad category, we talk about negative and positive symptoms. The negative symptoms are things like the flatness of affect, the blunted affect. And this is when individuals with schizophrenia may exhibit reduced emotional expression. They have reduced facial expressions and gestures and a lack of vocal intonation. And so they may lack the typical range of intensity that we see in people without the disorder. We also can see alogia, which kind of refers to the impoverished speech and reduced speech output. So basically, it just means that people don't talk much. Individuals with this symptom, they may provide some brief, very monosyllabic responses. Yep, nope, that type of thing. But they struggle to convey their thoughts really coherently. There can also be anhedonia, which basically just means a diminished ability to experience pleasure, or an diminished interest in activities that they may have once enjoyed within their life. And individuals may lose interest basically in social interaction and in hobbies and other pursuits that, at some time in their life may have brought them joy or would typically bring most people joy. With that comes avolition, which is a lack of motivation to initiate or sustain any kind of purposeful activities. So a person can be struggling to complete tasks. They can neglect their personal hygiene and withdraw from social and occupational responsibilities. And then with that comes asociality, which is basically a reduced desire to really be around anyone. And so a person with schizophrenia can be really kind of go into a state of isolation where they have little interest in forming or maintaining relationships with others. And all of these negative symptoms can really significant impact an individual's daily functioning and their quality of life, and undoubtedly is going to contribute to challenges in work and social relationships, as well as in self-care. And then there are, because we have negative symptoms, of course, there are also positive symptoms. Now, this doesn't mean that these symptoms are better. It means that you're adding something to the person rather than taking something away from the person. So positive symptoms would be things like distortions or excesses in normal functioning. And the first big one is hallucinations. And hallucinations involve perceptual experiences without corresponding external reality. There can be auditory hallucinations, such as hearing voices, or and these can be very common in schizophrenics. There can also, though, be hallucinations that are visual or olfactory, so smells, or gustatory, or tactile. And kind of the general rule is, if you talk to God, you are peripheral. If God talks back to you, then you probably are a schizophrenic, because that would be more of a hallucination. Now, the thing is that with hallucinations, the person typically does not realize that it is a hallucination. And so that is a big part of it. Then there are also delusions. And delusions are strongly held false beliefs that persist despite any evidence to the contrary. So common types of delusions in schizophrenia include paranoid delusions, which are things like believing that others are plotting against you, Grandiose delusion, so having an exaggerated sense of one's importance, and bizarre delusion, so irrational or implausible beliefs. There's also some disorganized thinking, which is reflected in speech patterns that lack coherence or logical structure. And individuals may struggle to organize their thoughts, and this can lead to difficulties in communication. There can be tangential thinking, derailment of thinking, and thought blocking. And all of these are examples of disorganized thinking. There can also be disorganized motor behavior that manifests as unpredictable or inappropriate movements. So this can include agitations, unpredictable body postures, or repetitive gestures. There can also be catatonia, which is basically a state of immobility and being unresponsive. Or sometimes you can have we call waxy catatonia, where someone can, end up with, say, one arm over their head. And you can move them so that they have one arm sticking straight out, and they won't change it. They will just hold that position for minutes or hours. These are just some forms of the positive symptoms, the abnormal motor behavior. There can also be impaired insight, though not always considered a positive symptom here, because it's a lack of something. But this impaired insight really kind of goes along with schizophrenia, because there's this irrationality that they are living in the true reality and everyone else is kind of missing reality. And so they believe oftentimes that there will be that they've been chosen by God to provide a special insight or a special message to the world, that type of thing. Now, as far as the basic numbers go with schizophrenia, now schizophrenia itself is relatively rare, with a lifetime prevalence, between a third of 1% to 3/4 of 1% in the global population, so a little bit less than 1% of the population. And the prevalence may occur across different cultures and regions, but generally is fairly well recognized as being universal, and men or women are affected generally equally. But the onset may differ, because men seem to experience symptoms a little bit earlier. Now, the typical age of onset of schizophrenia is during late adolescence or early adulthood. And usually in the late teens through to the mid-20s is when it starts to really become prevalent. But onset can occur really at any age, including childhood or in later life. And we would call this, for example, early onset schizophrenia, which tends to have a more severe course. Now, with the progression of schizophrenia, it's really marked by phases of exacerbation and then somewhat of remission. And the disorder often follows a chronic course with periods of stability that are interrupted by some acute episodes of symptoms. And the long-term outcomes really are going to vary from person to person. So we need to kind of be mindful that there are various stages that schizophrenia typically goes through. So you can kind of think of one phase as being the prodromal phase, where there's subtle changes in behavior and thoughts and emotions before the onset of full-blown symptoms. And this can include things like social withdrawal, reduced functioning, and changes in sleeping pattern. And then you get into the acute phase. It's characterized by the emergence of worsening of the positive or negative symptoms, and the acute episodes may lead to some hospitalization or more intensive interventions. And it's usually here that someone comes into contact with medical professionals that can then provide some medications for this. Now, following the acute episodes, you kind of normally would hit a stabilization phase where the reduced symptom severity is present. And here, treatment aims to manage the symptoms and prevent relapses during this period. And sometimes people will believe that they're cured from schizophrenia this time and go off their symptoms, which is unfortunate because you're not cured. This is a chronic condition. And so a person needs to kind of manage their medications very well throughout their life. And then there's the maintenance phase. And in this phase, ongoing treatment really focuses on preventing any further relapses and also managing any residual symptoms that haven't quite been managed adequately by the medications. Now, how do we understand schizophrenia? How has that changed over time? Well, we mentioned a little bit about how it's changed in earlier times. And in the DSM-4 in 1994, so in my day, I can say, so in the DSM-3, the DSM-4, we really talked about schizophrenia. So in the DSM-4, there were 5 subtypes. There was the paranoid type, the disorganized type, the catatonic type, and the undifferentiated and residual types. In the DSM-5, they tried to move away from that. So from 2013 onward, we tried to move away from that, recognizing that there's some limited reliability and validity to this. And so instead, the DSM-5 introduced a dimensional approach, emphasizing a spectrum of symptom severity and a more comprehensive understanding of the disorder. And so there's been an elimination of the subtypes of schizophrenia, recognizing that there is this mix of symptoms that go on here, and that there is some individual differences. Now, both DSM-4 and DSM-5 require the presence of characteristic symptoms for a diagnosis. So the thing is that DSM-5 emphasizes a dimensional assessment of at least 2 of the primary symptoms. So we're talking about things like delusions and hallucinations and disorganized thinking and abnormal motor behavior and negative symptoms. And these must be present for a significant period of time during a 1-month period. And within the DSM-5, we have a duration of these symptoms has increased. So the required duration of symptoms has moved from 6 to 12 months in order for there to be a diagnosis. And this recognizes that a more extended observation period may enhance the accuracy of the diagnosis. Now, understanding the neurobiology of schizophrenia involves exploring the complex interactions within the brain, particularly the role of neurotransmitters such as dopamine. So this kind of brings us to why the antipsychotics work and why it is the primary treatment for schizophrenia. Now, in order to kind of understand this, we need to talk a little bit about the role of dopamine. So remember, dopamine is part of the mesolimbic system, which is that central emotional part. And that is part of what is going on within schizophrenia. So we have something known as the dopamine hypothesis, which has been a predominant theory in the neurobiology of schizophrenia. And really what it suggests is that there is an overactivity of dopamine transmission in certain brain regions, and this contributes to the positive symptoms of schizophrenia, such as hallucinations and delusions. So within the mesolimbic pathway, there seems to be a hyperactivity of the mesolimbic pathway and the dopamine pathway projecting to the limbic system is associated with these positive symptoms. And then there's the mesocortical pathway. So there's a hypoactive component to the mesocortical pathway, which is another dopamine pathway projecting to the prefrontal cortex. And it's linked to some of the negative symptoms as well as the cognitive impairment. So there's a disruption in the dopamine functioning in different parts of the brain, and that is what causes these symptoms. And so what the antipsychotics do, sometimes we call these antipsychotics neuroleptics, are focusing in on modulating dopamine activity in the brain. Now, in the first generation of antipsychotics, chlorpromazine and haloperidol, these medications primarily blocked dopamine D2 receptors. And this reduced the overactivity of dopamine in the mesolimbic system. And there was some effectiveness in managing the positive symptoms, but less effective for negative symptoms. And when we disrupt these systems, there can be some disruption in what is called the extrapyramidal system. And there are certain neurons in your brain that are shaped like pyramids. And then there's some associated pathways that have some specialized functions in the brain, and those can be disrupted. So that's why we call this the extrapyramidal side effects. Then, so this was kind of the first generation antipsychotics. The typical antipsychotics were kind of more of a global management of dopamine and reduction of dopamine, essentially. And then when we get into the second generation of more atypical antipsychotics like clozapine and risperidol and olanzapine, these medications, they also block dopamine receptors, but they have a broader receptor profile. So they also can affect some serotonin receptors as well. And so this seems to be effective in managing both the positive and negative symptoms while potentially having fewer extrapyramidal side effects. Now, there's some interesting things as far as brain imaging goes. We see that there are some differences in the connectivity and the activity in different areas of the brain within schizophrenics, as well as there seems to be a very strong genetic component to all of this. So just all of this to basically keep in mind that the dopamine system seems to be at the core of psychotic disorders. And so we need to kind of be mindful that this is part of what needs to be part of the treatment, is some way of managing the dopamine system. Now, there's always been this perception that these bizarre individuals will be more violent. And so I kind of want to highlight that a little bit. The association between schizophrenia and violence has fueled a lot of media portrayals and societal misconceptions. And the research consistently shows that the majority of individuals with schizophrenia are not violent. And typically, the risk factors for violence among individuals with schizophrenia will include things like substance use and non-adherence to treatment, or presence of comorbidities and a history of violence. So basically, if the person tends to be violent, then that has nothing to do with their schizophrenic disorder. It has more to do with other personality factors or other aspects of their life. Now, there The protective factors that reduce the risk of violence in individuals with schizophrenia include things like their adherence to treatment, having a stable living conditions, and having adequate social support. So, in any developed society where there are adequate mental health supports, there is not going to be an increased risk of violence by a schizophrenic. It's rather things like substance abuse that will provide increased risk rather than the schizophrenia itself. So a schizophrenic that uses substances, particularly alcohol and illicit drugs, will have a significantly increase in violence. But it's really more about addressing the substance use as the instigator of the violence than it is the schizophrenia. Now, individuals with schizophrenia are more likely actually to be victims of violence than be a perpetrator, especially in the context of community violence. Now, however, there are times where the schizophrenic can be at risk of self-harm, and this can include things like suicide among individuals because they're just so frustrated with the quality of life. And so this is something that needs to be really emphasized in mental health care of an individual. Now, when it comes to the legal system, it tends to really recognize that the majority of individuals with schizophrenia are not violent offenders. And in cases where violence occurs, it is really essential to consider the specific circumstances, the adherence to treatment, and the presence of any other risk factors, rather than blaming the schizophrenia. Now, when it comes to effective management and prevention, this is going to involve a comprehensive engagement with mental health care. So it includes having access to adequate, appropriate medication, to therapy, to support services, to also have any appropriate intervention for things like substance use, community supports, family supports. All of that is going to go a long way to ensuring that the individual is not involved in violence and also is not the victim of violence. Now, there have been cases where someone that has schizophrenia has done an act and may have been motivated by their disorganized thinking or their delusions. And there have been some very prominent ones. One example of that is John Hinckley Jr. Hinckley, he gained notoriety because he attempted to assassinate President Ronald Reagan in 1981. Now, Hinckley had not been diagnosed with schizophrenia at the time of his attack, but it did come to light later on that he was apparently suffering from schizophrenia. Hinckley was born in 1955, and he had lived a significant portion of his life obsessed with certain things. For example, he had a profound obsession for Jodie Foster, the actor. And one of the reasons, and this just goes to show some of the disordered thinking there, that he attempted to assassinate the President Reagan, was to impress Jodie Foster, the actress. Now, in the trial that followed this, Hinckley's defense argued that he was suffering from schizophrenia, and therefore his actions were the result of a delusional belief system. And Hinckley was found not guilty by reason of insanity. And so he was treated at the St. Elizabeth Hospital in Washington, D.C. in psychiatric treatment. And over the years, Hinckley's mental health improved. The medications certainly helped. And in 2016, he was released from this psychiatric care and he was allowed to live with family members. Now, of course, there were certain conditions, but this just goes to underscore the complex relationship between mental illness, particularly schizophrenia, and violent behavior. And it also raises questions about the legal and ethical considerations surrounding individuals with mental health disorders who engage in acts of violence. So, while such cases are exceptional and not representative of the vast majority of individuals with schizophrenia, they do contribute, obviously, to the public perception of schizophrenics as being violent and dangerous. And because of the bizarre behavior that they display, that just emotionally gets people upset. Now, there is clearly a stigma associated with schizophrenia, and this is something that remains a significant barrier to understanding as well as to empathizing and for people engaging in effective treatment. But I think destigmatization of schizophrenia is really crucial for fostering any kind of compassionate and supportive society. And so there are a number of things, I think, that we can do to change public attitudes. One is educating the public. As mental health professionals, we do have a responsibility to provide increased public awareness and understanding of schizophrenia. This can be through community engagement, it can be through the media, it can be through education. What we need to do is dispel the myths and provide some accurate information and showcase the diverse narratives that really contribute to a more informed and empathetic community. It's also important to share personal stories, to humanize people, to recognize that a person is not their illness. A person may suffer from schizophrenia, a person may have schizophrenia, but that doesn't make them just a schizophrenic. They are a mother, a father, a daughter, a son. They are a lot of things in life. And it's important to highlight the achievements of these people, to recognize their resilience and the many diverse journeys that they've gone through, so that we can, really celebrate them and their lives in the midst of their challenges. It's also important to try to think about how we use our language, where we should, try to get away from using derogatory terms. And, I do it myself, even in this lecture. It should be individuals with schizophrenia rather than the schizophrenic. And this is going to go a long ways to perpetuate the negative stereotypes. I just find myself following back into it because of old language that I grew up with. We should also encourage very accurate and empathetic portrayal of schizophrenia in media, something that can counteract the harmful stereotypes. One of my favorite shows is actually a show called Perception that highlights a neuroscience professor who lives with schizophrenia and some of the challenges that he has in the midst of that, but how his genius still shines through in the midst of all of that. Of course, we should have community supports, create supportive communities for individuals, and this isn't just for the individuals, but for the family members as well. I've had many support groups where one of the things that the family members are looking for is just a way to understand why is this happening. And when they learn about the dopamine system and the disruption in the system, it just takes a huge weight off of their shoulders, because people tend to fall into, in the absence of any real understanding, tend to fall into myths and legends and bizarre religious beliefs about what is going on with the the person with schizophrenia. Access to treatment, also very important. And this has to do with not just access, but affordability, having a cultural sensitive community where someone can be encouraged and not be insulted by being encouraged to seek out help for schizophrenic symptoms. So all of that can go a long ways to change the stigma. And it's something that's really going to require our collective effort as individuals and communities and institutions. And yes, we will fail at it from time to time, as I fail regularly about it. But it's important that we strive to be more empathetic, more supportive for individuals with schizophrenia. And just a few terms to kind of highlight here. Things like psychotic disorders. So you just need to kind of be mindful that this would be a group of mental disorders characterized by a loss of contact with reality. This is going to involve hallucinations, delusions, disorganized thinking, and impaired insight. Then there are positive symptoms, and these are symptoms that represent excesses or distortions of normal functioning. So things like hallucinations and delusions and disorganized thinking and abnormal motor behavior. And then there are negative symptoms, and we can think of things like deficits or disruptions in normal functioning, like a flatness of affect, alogia, or anhedonia, or avolition, or asociality, asociality. All of those things would go a long ways to understanding. So a few final thoughts as we close out this lecture. The thing to kind of be mindful of is that we need to have a holistic understanding of schizophrenia and psychotic disorders in general. Remembering that schizophrenia is a complex and a multifaceted disorder with a range of symptoms, including the positive and negative and cognitive features. And that a holistic understanding of the biological, the psychological, and the social factors needs to play into it, recognizing that we have done a lot to grow and develop and to better understand these psychotic disorders through research, through treatment, and through a push for destigmatization. And that the treatment of schizophrenia has really evolved over the past century or so, going from those early somatic interventions to the revolutionary impact that we have today with psychopharmacology. And that the advances in neurobiology, particularly relating to the dopamine hypothesis of schizophrenia, has really helped to shape our understanding of schizophrenia and has led to these antipsychotic medications that target those neurotransmitter imbalances and help us to better manage the symptoms associated with schizophrenia. So, I hope you've learned something in this lecture, and as we draw closer to the end of this course, I want to thank you for engaging within this course. I've enjoyed teaching you, and I just encourage you to continue on with your learning and to always, always, always consider the psychological aspect, the genetic, the neurobiological aspect, the neurochemical aspect, the social aspect, and to work with people as human beings, showing them empathy and inclusion, and providing them with the best access to support and care and mental health services. You take care. I'll see you next week. Goodbye.